started. Okay, looks like we're good.
Right. With that, thank you, Representative Wood. I'd like to call to order today's meeting of the Insurance and a public hearing of the Insurance and Real Estate Committee, pursuant to a public act passed in 2019. We asked the Insurance Department to collect data on non-quantitative treatment limitations imposed on by insurance companies trying to understand mental health parity. This is the that act then required us to look at the data and instructed us to hold a public hearing by May 15th of each year. I want to preemptively apologize to members of the committee and the public because, as many folks know, the Senate was in late the last two nights, and I have a new constituent who's been taking up much of my time. So if I'm a little incoherent, I apologize. But this is an important hearing because it gives us the first opportunity to look at the data being collected by the Department of Insurance and also hear from the public and from relevant stakeholders about how mental health parity is going. And so with that, our only scheduled officials are from the Department of Insurance, and then we'll hear from some members of the public afterwards. And so I want to turn it over to the Insurance Department without delay to hear more about what they found, and we'll go from there. So first up, we have Robert Chester and Curt Swann from the Connecticut Insurance Department. Good to see you this morning. You have to unmute yourself.
Okay, can you hear me now?
We sure can. Go ahead.
Okay, Senator Lesser, Representative Wood, Senator Wong, and Representative Pavlik D'Amato, and members of the Insurance and Real Estate Committee. My name is Curt Swann, and I'm the Director of Market Conduct at the Connecticut Insurance Department. Thank you for the opportunity to provide remarks regarding the requirements of the NQTL reporting as part of Public Act that was passed back in 2019 and codified under 38A 477. The Federal Health Parity Addiction Equity Act, or commonly referred to as MAPIA, prohibits health plans from imposing non-quantitative treatment limitations, or NQTLs, on mental health and substance use disorder benefits that are more restrictive than those used for medical surgical benefits. And the carriers are required to file reports with the department, which we have reviewed and assessed on the basis of the following areas. One, the carriers have explained and demonstrated how they developed and selected each medical necessity criteria within each benefit group. They've also submitted and identified and listed all the medical necessity criteria and NQTLs being applied within each benefit group. And finally, the carriers have been able to demonstrate and compare the evidentiary standards supporting the applied medical necessity criteria and the NQTLs. Now, what that means is that we assess and consider the effects of these benefits and the limiting factors for their as-written application and for their in-operation impacts and for the actual impact on the final outcome. The expectation is that the NQTL components, such as prior authorization or concurrent care review practices, would be applied to mental health and substance use disorder benefits comparably and no more stringently than they would be applied to medical surgical benefits. While the outcomes are not determinative of compliance, disparities in the outcomes, such as denial rates or other outcome measures, are an indicator or a warning sign that there may be parity noncompliance. And hence, the outcome measures are essential to complete the NQTL compliance analysis. For the data that was submitted, the department found certain instances where the data supporting any incongruent benefit outcomes was often omitted or insufficiently provided and analyzed. Also, there were certain instances where documentation was not sufficient to demonstrate a comparative analysis process that demonstrated congruency between the as-written, the in-operation, and the final outcome. I think it's also important to note that recent guidance provided through the 21st Century Cures Act emphasizes the need for more examples of compliance with the law. This includes best practices for establishing an internal MAPIA compliance plan, and also provides examples for the types of records that carriers should be prepared to provide. The Act emphasizes how the internal compliance strategy that promotes the prevention, detection, and resolution of potential appeal violations can help carriers improve compliance with the law. In addition, the DOL provided an updated self-compliance tool to better ensure that carriers have the sufficient guidance going forward to ensure that this comparative analysis is performed. That completes my remarks, and I would be happy to answer any questions you may have.
Thank you, Curt, for that. And I guess I'm a little frustrated. First of all, I appreciate that information. You mentioned that in some cases the data that was provided was not sufficient. What is that because the internal MAPIA compliance practices weren't yet in place? What's the explanation as best you can for why that's the case? And does the department have a plan for collecting that data going forward? I'm just trying to figure out what the barriers are to collecting the data that required.
I think, Senator, one we found the data that was provided was not sufficient. I think one reason could be, I think there hasn't been sufficient clarity and guidance with that. I think the Cures Act provides that additional guidance. That's one piece. We have recognized through the first time through with obtaining this data and going through that we've already reached out to the health plan representatives. I think we're looking at improving how the data is acquired and streamlining that process and working on best practices to ensure that we get the appropriate data and meaningful data to ensure that we can improve on what's being reported to the department. So I think that's the approach that we've taken. And I think we've already had discussions with the health plan representatives to work on that. So next year, hopefully we'll have a better product.
I could add to that, Senator. It's a good question.
And I'm sorry, could you please just identify yourself for the record?
Bob Chester from the Insurance Department, Market Conduct Examiner.
Right.
The federal parity law came out in like 2010, and it was very clear that on the two components that we were to look at non-quantitative treatment limitations, they split it for this report. The examination only focused on the non-quantitative treatment limitations. They had the other segment, quantitative treatment limitations, but the focus has always been parity between the three benefit classes: the mental health, the substance abuse, medical, surgical. It was very clear that the non-quantitative treatment limitations that were to be assessed from the beginning of that law were to look at the as-written standards and factors and sources for those non-quantitative treatment limitations in the delivery of the managed care benefits, and when they actually are applied in application or in operations. So it said that you have your as-written standards, and then managed care is a complex entity, and they have all these components that can go into the factors in creating these NQTLs, and their process in delivering the final outcome. That they said that they have to maintain this comparability assessment on those in operational practice as applied. What we discovered in this report, and it gets to your point, was it wasn't entirely clear on what the disparity was on the final outcomes, the actual claim data, which is as important as the as-written NQTL standards that are limiting the benefits, and the in operations, which was clear in the law. And of course, the final outcome is an imperative component to look at of the whole life cycle of the NQTLs. And that's where the department found there could be or needs to be some improvements taken, which the industry, I understand, is willing to do that. But in fairness, that wasn't clear what those factors were to define what was incongruent on those final data outcomes from the claim data. what defined a substantial disparity in that. It was improved through the self-evaluation tool that was compiled, but it wasn't entirely quantified. We now understand that part of the NQTLs and to regulate and to look at managed care and all these benefit limitations to make sure they're comparable and compliant with parity, that it involves the as written standards, the in operations which were there since 2010, and now absolutely the final outcomes, that there's an expectation that the carriers have to provide a same level of comparative analysis that they did for as written and in operation with the final outcomes to pinpoint why these disparities are there on their incongruent outcomes. And if the law, the federal parity law does allow, because they're not apples to apples between mental health, substance abuse, and medical surgery, there are clinical standards that can be comparable the way the law is written, but that justifiably produce these disparate outcomes and incongruent outcomes. And the expectation now is that the carriers, if that's the case, should be able to demonstrate that to us. And that's where there's room for improvement.
So thank you for that. And maybe I'm confused by what Curt said a minute ago, but my understanding is that the 21st Century Cures Act passed in 2016. So the carriers have had 5 years. So if there is guidance about compliance baked into that, I'm frustrated and not sure why they haven't done that by now. And so but is the department's sense that by the time the next tranche of data comes back next year, that they will be in compliance? Or is that in terms of providing the comparable, the comparative analysis required, et cetera? Are we expecting there to be data gaps going forward, or is this the final nudge that we needed to?
Well, I think, Senator, the Cure Act, the recent information that the feds have put out provided more examples and clarity and guidance. And I think that's the key point, to follow up on what was passed prior. And I think it makes it crystal clear for the carriers of what is expected. And I think that was the point I was trying to make. And it provides that guidance. And I think it's also some findings that we have found prior to the reports that were provided, where this comparative analysis is important to be provided. And it's something that we will follow through and work with the carriers to ensure that it is clear with what's expected, and ensure that the documentation is sufficient to demonstrate that they are in compliance with the NQTLs.
Great, thank you. And I understand that there was some recent enforcement action that the department has taken with regard to one major carrier regarding NQTLs. Is there any information that you could provide the committee on what happened, and to the extent that you can speak publicly about that?
So I think there was one carrier where we conduct review, and we're also in the process of reviewing other carriers specific to the NQTLs. And I think the finding there was that the comparative analysis was not sufficient. We identified that as a finding. And we also assessed a penalty and ensured that there's a corrective action plan to ensure that that information is provided. And we will follow up on that to ensure that they're meeting that requirement.
And can you tell us which carrier that was?
That was United Healthcare and Oxford Health Plans here in the state.
Okay, and the penalty was what, $600,000 that was assessed? Is that?
The penalty was a little over $500,000, but that was for a comprehensive exam, a specific parity review, and some findings specific to utilization review criteria that was not being, some findings specific to some utilization review criteria.
So do you, I mean, going forward, you're going to be getting more data, and hopefully carriers will be following the federal guidance and providing the data that we need. Is there anything that the department needs to have more tools at its disposal to make sure that you're getting the data required by law in a timely manner, and so you're and making sure that we're getting the comparative analysis that we need. Is there anything else the department needs at this point, or do you feel confident right now that based on new federal guidance and the enforcement tools of the department currently, that things are copacetic and we should be good going forward?
Yeah, I think the department could always use resources, but we have been having training provided specific to mental health parity and NQTL, and we have some additional training scheduled in the future for these issues. And I think that would be sufficient. I also think the federal guidance will help a great deal to make it clearer with what the expectation is, to ensure that there's a clear understanding of what's expected. And I think we just need to follow through and make sure that all the carriers are consistent with what they are providing.
Thank you. I may have additional questions, but I see several members have their hands up, so I will turn it over to members of the committee if they have any questions, and then we'll go from there. Questions or comments, members of the committee? Yes, Representative Nuccio.
Good morning. Good morning, both of you gentlemen. How are you?
Good morning.
Good morning.
So I have a few questions for your market conduct exam. Have you standardized your NAIC template yet? I know there were talks within the last 6 to 9 months with NAIC on standardization of templates for the requests of information. Has Connecticut gone to one of the standardized appendixes?
Right. We have incorporated components of that. And doing that, I think we're also looking at the revised self-compliance tool and ensuring that we have the components of that included in our review. I think one thing that we've identified is that we need to improve on the data that's being requested for the reporting there. There is also an NAIC working group that's working on that.
Yeah,
and I think we're still in the process of finalizing that complete NQTL, but I think we are certainly, I am on that committee, actively involved. And I think when we get that refined, we should be in a bit better shape for the tool that we are using to gather the information. And I think that's something we consistently monitor and incorporate. And I think that's something we already mentioned to the senator, that's something we're looking at best practices to ensure we get the correct data.
And Representative Nuccio, I would add to that this touches on what Senator Lesser pointed out on things to close the gap, if you will, with what we discovered with final outcome data on these NQTLs. That the NAIC working group is great because they've established best practice standards now that will be uniform, that everyone can use, and it makes very clear, very, very clear, that the final outcome data is key, and that there's the obligation on the health carrier to do this more in extensive, in-depth, granular demonstration of comparability when there's disparate results or the results are incongruent from actual claim experience and claim data between them.
I can tell you from personal daily experience, I absolutely agree. Every state seemed to have their own template, different ways of doing it, different ways of gathering information. So the NAIC stepping in to kind of have a standardized reporting option has been grand. So I was just checking to see where Connecticut was on establishing that. And from the perspective, I think it's probably good for people to understand the difference between the NQTLs and the QTLs. So and how we're reporting the information. But more importantly, just as one quick set aside question, the fines that were issued, they're related to the market conduct exam, correct? And not the NQTL, like the specific MAPIA, NQTL, QTL reporting. It's a market conduct exam, correct?
That's correct.
Yeah. So
it was a market conduct exam, correct?
Right. Okay. So the NQTLs and QTLs. So for the NQTLs, you're looking at things like step therapy, like application of therapies and stuff like that, not the cost share parity perspectives to make sure we're in compliance with how cost share is attributed across mental health and medical, correct?
Correct. That's the quantitative treatment limitations. It's that the financial requirement. It has specific numbers on physical therapy, how many times you can actually go.
Right.
So that's all part of it. There's a cumulative financial amount in the plan, all the cost sharing components. That's the quantitative treatment limitation. The non-quantitative treatment limitation components are actually, there's a lot more of them.
A lot.
A lot. And it changes and evolves as efficacy and clinical efficiency and cost change, markets change. Right. So that's a moving target. But for this report, we focused on 13 of them, which is a uniform standard that it's in the self-compliance tool.
Okay, so you're looking at pretty much the standard set of NQTLs then? Because I can say that the hardest part when insurance carriers don't receive extremely clear guidance on how you want these mapped. You're talking about comparing qualitative treatment limits for medical health to subsequent mental health, and then trying to map those, because they're definitely not always one-to-one, right? We know that. You know that when you have therapy for a medical health issue, it doesn't necessarily map to a mental health. So from this perspective of the state, are you reaching out and working with the carriers to be sure that the mapping is consistent across the industry to what you're requesting in your MCE?
The parity law keeps it. See, now you're making me to get into the context of the question. I got to provide a little more summary of this.
I think that's beneficial for people because we throw around key terms, NQTLs, QTLs, and mapping. A lot of people don't understand the industry jargon. So
okay, I'll attempt to explain it a little bit. The law was maintained loose enough because, as you're pointing out, mental health and medical surgical benefits have different clinical standards.
Correct.
And different practices to manage and deliver that care, which are acceptable. So they wrote the federal law to keep it pretty generic enough that you could put it into these specific categories or buckets to look at the non-quantitative treatment limitation by general factors and sources within these areas to make sure that the practices are comparable and no less stringent within between the benefits to make sure that they're in parity. So they looked at, you have the three benefit classes: mental health, substance use, and medical surgical benefits. And then what they to call out is sub-classifications very generically: the inpatient, in-network, inpatient, out-of-network, out-of-patient, in-network, outpatient, out-of-network, emergency care, and prescription drugs. So then that comparative analysis is done in that way. And again, we looked at in this report for the non-quantitative treatment limitations that limit scope and benefits. There are ways to restrict, which are entirely that are entirely permissible in managing healthcare, the costs, variability, and so forth. Well, the NQTLs, as I said, we looked at 13 of them. There's a lot more, as you pointed out, but these are the 13 most common. And so there is a quantitative approach that we took that's reasonable based on the numbers. So you have these NQTLs, and we look at how they're developed, the factors themselves, and the factors that go into them are things like medical management practices that limit the benefits based on medical necessity, all things that we know as being in the industry: medical appropriateness, experimental or investigation, prior authorizations, concurrent review, prescription drug formulary designs, network tiering, provider network standards and reimbursement rates, methods for determining the usual and reasonable customary rates, step therapy or no fail first practices, treatment exclusions, specific within the benefits within those subclasses, billing code practices or nuances that often occur, access to out-of-network providers, exclusions for failing to complete course of treatment that was required. They do that a lot to exclude. Restrictions related to geography, facility types, or provider specialties. So those are the factors in developing the NQTLs. And then there's general categories of sources when we're looking at those between the benefits, between the subclasses, to look for this comparability and this stringency assessment that's required in parity. And that the sources look at things like excess utilization, medical cost escalation, provider diagnosis discretion, lack of clinical efficiency or efficacy, high cost variability, variation, volatility in the length of stay for inpatients, adherence to quality standards or non-adherence to the quality standards, claim type, actual experience. They look at specific benefits or treatments or services that have high rates of fraud, current and projected demand for services and treatments. And that kind of goes more into the weeds than I thought. You asked, so
I appreciate it. I think these are important conversations to have, because when mental health parity came out, of course, the main focus of the government, all of the states, the federal government, and the carriers was really focused on the QTLs to make sure we had parity in cost, parity in application. And I think the industry's had time to adjust to that. And this helps, right? It helps form benefits. It helps form what's available to the insureds. Because if you try to build a plan that does not have parity in it, that parity level fails, and legally we're not allowed to sell a plan that is not in parity without having severe fines, right? So it helps dictate conversations with employers who are the ones who are buying the insurance, to make sure that they're building plans that have comparable mental health benefits with medical benefits. So that was really the focus for a long time. And NQTLs were kind of there, but not really fully developed, and nobody quite knew what everybody was focusing in on. And like you said, it's a very vast field, because even if you look at an inpatient stay on a medical side can be 7 to 10 days for a diagnosed illness. A inpatient stay for a mental health or substance use can be 90 days. So looking at the comparability of medical to mental health, there are intricacies that need to be taken into consideration. And I appreciate that we're getting there, because we just passed a mental health bill the other day, which talks about something you mentioned, which I think is very big in the NQTL area, and that's depth of bench when it comes to mental health providers. And you look at how deep is your bench on a medical side for PCPs. Now, how deep is your bench on a psychological side? And it's very shallow bench comparatively, and that's an NQTL, right? So this is helping drive the conversation of making sure that we have enough providers and enough services. And again, there's a lot of murkiness between matching medical to mental with that, but the conversations can be had that will help reduce that. I have one other quick question. I could sit here and talk to you about this all day and talk about the forms and how to work better with industry to get the information that you want and the clarity required. But how are you finding, because I know, again, this is one area that has even been less focused on yet and is just starting to come up, but how are you finding the RX and QTLs? Because formularies and reviewing the adequacy of formularies in relation from a medical to a mental drug formulary perspective. I'm sorry, I'm making your morning miserable, aren't I?
No, I mean, it's an excellent question, Representative. It gets a little thorny, and we've had some pushback on that. I mean, without getting into the weeds, there's a lot of the prior authorizations on the formulary, trying to line up the formularies with the types of drugs. in the formularies between the benefits, the medical and surgical, volume dispensing, quantity, amounts. As a department, we're getting much more in the weeds on that. But there's you can get a generic apples to apples to do the comparability assessment. The department believes on some, for instance, something like prior authorizations on the pharmaceuticals, that you can look between the benefits and see if there's, you can follow through the development factors, as written and in operation. And then also that final check on looking at the final results. I can give an example. It comes to mind because it happened with a few of the carriers. I asked for all the data, and I look at the formulary, and I look at their as written standards for something like prior authorization. That's really common with the within the formularies. And I look at the as written and comparability, how they're developed, and then they're in operation charts and demonstrations, and their practices are comparable. There's no real stringency issue that shows up. But then when you look at the final outcome, there's a difference. From an as written standard perspective, the total volume within the formulary, within the mental health drugs and the medical surgical drugs, reflect a higher frequency of prior authorizations on medical surgical, which is fine. But then the final outcome shows a significant, in the actual claim experience, the frequency occurring within substance abuse or mental health and not medical surgery. So it's opposite of what the prospective prior authorization requirements are on those drugs. So there's some explanation and backing in and saying, okay, well, there could be a justifiable reason, a clinical reason to account for that, because they're not always apples to apples. And that's kind of where the department is going in doing a whole 360-degree view of this process to make sure we don't have any loose ends. And in the industry, from what I understand, is willing to work to improve the process.
I think that's my overarching thing here. Mental health parity is, as you can see from the last, 15 minutes of the questions that you and I are talking about, right? All the intricacies of how mental health parity, the law works, and then the application and the ability of the state to understand it and request the information from the carriers, and the carriers to be able to translate that into claims and then into prior auths. A blood pressure medicine is much different than a schizophrenia medicine. Both of them would have a prior auth. Both of them could possibly have a 90-day, thing up prescription. But laws that we've put in place regarding psychotropic drugs don't necessarily meet up with the allowability of that. So we create some of the problems that we have. And I think overall, there's a drought of information from the perspective that there's so much, and industry and the states have focused in on, first and foremost, do we have parity in pay, parity in how we're applying the benefit aspect of this. And now we're really all starting to kind of trying to dig into the rest of it. And I think it's a partnership. So I just like to recognize that it's very complex, and the relationship, at least the relationship that I've had with the state and in the carrier that I've worked with, it's a partnership. We need to understand what you want. They need to understand, they need to understand what they need, so back and forth. I appreciate the openness and the ability to be able to continue to work on this. So we're looking at truly how we can get to parity. And I think industry and the states have done a good job of focusing in on most important thing first, next thing, and getting all the way down through all of this to have standardization of forms, understanding of what's coming. So when we talk about companies being out of compliance, I think it's important to recognize the confusion, how easy it is to not understand exactly what it is a state is looking for, or what it is industry can provide, and continuing to work so we can start to look at things now that will improve mental health parity, like depth of bench, and understanding the differences between that inpatient stay for medical and an inpatient stay for mental health, and the differences between a prior auth for a blood pressure med and a prior auth for a schizophrenia med. I think everybody's trying to do the right thing, and I do think that standardization of the forms that industry is requesting, with good mapping to be able to understand the claim volume. Because the one thing I don't think a lot of people realize, when you start talking about mental health parity, everything is based off of medical claims. You do not get claim dollars for mental health. It is medical claims that are being projected. And then the cost share benefits for those medical claims compared to the cost share benefits for mental health, because mental health is very complex. So there's a lot in here. I appreciate you going down Alice's hole with me there for a little bit, just because, I do this every single day. I'm in the middle of 5 market conduct exams right now. So luckily Connecticut's not on my list, but understanding how this works, I think, is very important for the insurance committee. So the narrative doesn't get turned into industry is not compliant. It's that it is severely complex, and it's baby steps to make sure that we get there. And it's the state is doing a great job of really making sure that we're driving benefits and plans in conversations with employers that create an environment where mental health is prioritized as much as your regular wellness visit is mental health. And there's so much more that we can do to do that. But this testing helps. And the fact that we're really starting to zone in on the NQTLs now, because, we're all good with the QTLs. Like, we can't sell plans like that, and we can't let providers build plans that are not going to be in parity. But the NQTLs, it's a twisted weave of craziness. And I appreciate everything that you guys are doing to try to kind of standardize at least those 13. And I look forward to working with you in any way possible, anything that you need to try to help get into the mind of industry if you want. I make myself available to you at a drop of a dime if it will help. So I want to thank you very much again for going down Alice's hole and answering my questions. So thank you very much.
Thank you, Representative. And I will say I appreciate that deep dive into the weeds on this, but I do take issue with the question of the industry taking baby steps to comply with the law, because mental health parity has been the law nationally since at least 1996. They've had decades to comply with the overarching policy goals set by this state and by the federal government, which is that insurance companies should treat diseases of the brain just like diseases of any other part of the body. And this law that we passed in Connecticut, we passed 2 years ago to try to figure out why NQTLs were springing up as additional barriers for people getting the care that they need. And I'm frustrated that the department is today saying that the industry, despite additional guidance from the federal government, despite the DOL self-analysis that was described, the 21st Century Cures Act guidance, is still not getting the data that they need from the insurance companies that is required by law. And while I respect that the industry is making baby steps to comply with the law, I don't think baby steps are sufficient. So I am personally frustrated that we don't have more compliance. I'm hopeful that the next time we have this hearing, we will see an industry in compliance with the law. But frankly, I see folks dragging their feet over decades and imposing new barriers as policymakers in states and the federal government try to solve problems, new problems get created. So I dispute the characterization that people are moving to address this, but I do agree with you that they have been taking baby steps. hopefully we will no longer see baby steps. Yes,
Sir,
Representative.
I would just like to kind of answer back to that. I think there's, as you could see from the conversation, there hasn't always been clarity. You're talking about 50 different states that are asking for things in 50 different ways. There has not always been clarity on exactly what the state wants and how we map that. So it's not that there's any intentional baby steps being taken place. This is a process. You've been asking the state to get involved with carriers to discuss mental health issues. Every state sees them slightly different, and how an industry maps claims from that perspective to reporting that doesn't necessarily match up, even from the perspective of how they want it classified. It's not that industry has not tried to provide this information, but if there isn't clarity from the state and the templates, something as simple as how the templates that they're asking us to fill out, I don't understand how we can provide information that there's no clarity that the state doesn't understand exactly what they're asking for to provide. The mapping between the two areas just comes down to a simple conversation of exactly how to provide the information. So it's not that mental health parity isn't a priority for industry, or even more importantly for employers, because they're the ones who drive the benefit summaries. It comes down to how can we report to the state in a format that they want, that we can provide, that easily maps. So it's not that industry isn't trying. There has not been a lot of clarity from 50 different states on how each individual state wants to report this information. So the fact that NAIC has recognized that and is looking for standardized templates across the country, because of this lack of clarity, it's easy to look and point a finger at somebody and say, you're not doing your job, when you're not providing the tools that you want for that person to do. So the fact that we're providing more standard templates and better mapping tables and an explanation of exactly what they're looking for, it's easy to point to somebody and say you're not doing something when you're not providing the information to help them do it. So in all fairness, I think there's enough shared blame to go around. And I think also there's enough willingness across industry and the states to work together to provide true mental health parity for everybody. There's no person out there maniacally twisting their mustache saying, we don't want to provide this. Across the boards, mental health is one of the top priorities of the country, I would say right now. And I don't know a single person out there who's stomping their feet saying, we're just not going to do this. So in fairness, I understand your frustration. I accept your frustration. I absolutely think it's valid. I just ask that you recognize that it's not intentional or maniacal on anybody else's perspective. Help me help you. That's what it comes down to. So we can't provide information that we don't understand. And I say this from the personal perspective as somebody who fills these out for 50 different states with 50 different templates and 50 different expectations of how that information gets there. So I'm very thankful for Mr. Chester coming and talking about this and recognizing the fact that there isn't clarity in these forms and looking for ways to make this better, because this reporting is important and us doing it correctly is important. And you in the state, us again, receiving this information to understand it is important. So I thank you again, Mr. Chester, for the information and the back and forth.
Thank you.
I just want to go ahead, Mr. Chester. I don't know if you were going to say something. No, I appreciate that perspective, Representative. I just want to clarify our role here. As members of the Insurance and Real Estate Committee, we are overseeing the department and seeing their compliance with the law and seeing how industry is complying with the law. I think we're going to hear later from the industry itself, and so that's the appropriate format for folks to talk about that. And I appreciate that we have an opportunity to do that. But we have fulfilled an important oversight function, and what we heard from the department was that industry is not complying with the law, and that is problematic. We also heard that there has been additional guidance from the federal government to ease that, and yet they're still not complying with the law. And that to me is concerning, especially since this law was passed 2 years ago, following up on previous parity laws that have been passed And the reason we needed to pass a law 2 years ago was because the industry had erected new barriers. And so we will hear later from the well-compensated representatives of the industry who will share their perspective about additional barriers. But I want to be very clear on what our function is as the Insurance and Real Estate Committee, which is an oversight function and an oversight function alone. So thank you, Representative, and Representative Meskers, I see you have your hand.
Yeah, thank you. So I probably have a different perspective than Representative Nucio in terms of going to the compliance issue, the regulatory framework. You're dealing with both the federal law and requirements at the state level for regulatory oversight of the industry for compliance with these measures. So your report, what percentage of the industry in Connecticut are you covering? Are you covering the self-insured? Are you covering just the public markets, or are you covering any of the fully insured products? So I'm trying to understand, like, what percentage of the industry we're getting a report on here, and where your oversight lies on this.
Right. We are just covering the commercial market, so that would be the fully insured market.
Okay, so you wouldn't have any oversight of either the state employees' healthcare and or the municipal plans as they're currently formulated. Is that correct?
That's correct.
Okay, so it's a limited scope of who you're reviewing at this point. And well, I heard the back and forth with my esteemed colleagues, but what I was hearing, and I can't get all the initials right, nor am I looking forward to memorizing the initials you repeat to me, God bless you. But what I'm hearing is that there was a regulatory framework put in for oversight for compliance, but that the forms and the structure and the standards of the reporting were not very clear as well. And that we're getting more guidance from NAIC as we're going forward. Is that true, and how we're looking at this review process?
I think as we've reviewed the information, I think we're looking at improving the reporting and looking at best practices to ensure that we get the information that we need. But I think it's important to note that, with the information that we did receive, we're not saying that they were non-compliant. It was more that we didn't see clarity, or we didn't feel that the comparative analysis specifically in the in-operation was sufficient for our review. I think that was the concern that we raised.
And that is again, just to put it in layman or English terms, that is in compliance with new regulatory framework and how they filled out the forms and reported. There was a problem in getting the compliance because there was a problem with the framework of the reporting. Would that be fair to say? Or understanding the framework of the reporting?
Maybe understanding what the expectation is, and I think getting more guidance. But I still think we look at it. It is the carrier's responsibility to demonstrate compliance by providing documentation sufficient for our review. And I just think, based on our review, that we didn't feel the analysis provided was sufficient.
Could I point out?
But hold on. But it's like asking an SAT question without a framework for the response. And the question is whether I get 0 or 800 on that SAT, right? So I'm trying to understand how much was negligence, lack of cooperation, filling out the form, trying to figure out what the requirements were in, we write laws, and if someone doesn't give me a framework how I'm supposed to fill out my reporting requirement, I may miss the reporting requirement, and I'm technically in violation of the law, right? I'm trying to understand this from that point of view.
Representative, I'm going to attempt to answer that. It's probably not a great answer, but Representative Nucio pointed out that it is a structure, and it is clarity of the regulations. The quantitative treatment limitations, for the most part, were a slam dunk. Quantitative means, numbers, it's clear, it's in black and white. And there was never—
I was a banker. I was a banker. I can measure quantities.
So there was two-prong approach under the federal law, the quantitative treatment limitations, and there hasn't been any struggle with that. The non-quantitative treatment limitation is kind of an unwieldy, imprecise structure. And it's unclear across the country with many states. And that's why Curt and I are on that NAIC working group now, specific to developing best practices for the non-quantitative treatment limitation, because there's been so much pushback, so much conversation saying we're struggling here to understand what you expect from us in demonstrating that the non-quantitative treatment limitations are comparable within the benefits.
Oh,
And we just want further clarity. So I think the issue, to answer your question, is that the structure is set up as written was unclear to all of the stakeholders. And I think that's fair to say.
Representative, are you still there?
I think he got bopped off.
I think we lost Representative Meskers. Representative Farrar, we can go back to Representative Meskers if he can resolve his connection issues. Representative Farrar.
Thanks, Chairman. Hi, gentlemen. Nice to see you. It could be where my fellow representative was headed, but I'm actually interested. I certainly kind of hear where we're at now. I'd really like to hear from both of you to reiterate, how are you going to ensure that we're in a different place with reporting a year from now? I'd really like to understand kind of the process steps to get there.
I think first off, it's just working with the carriers to understand what clarifying what the expectation is. I think working on the reporting tool with how the information will be gathered and reported to us, and working through that. I think one, as we've mentioned before, it's the in-operation comparative analysis and how that's reported. And it's really drilling down in that area to set what the expectation is, providing guidance, providing clarity, and also working on what the reporting tool for reporting that information to us. And I think if we can work on being clear with what the expectation is and ensuring that the carriers are consistent with how they provide that, it will allow us to conduct our analysis in a much more efficient way.
And I could point out also that to Curt's point, this was the first time that it was new for us regulators, and it was new for the industry. And I can tell you that we've had so much conversations with the industry through this to work through it. And we have set very clearly in many meetings with them that this is now the expectation. And so next year, it's not going to be so much, we were not going to have to explain the process and clarify it as much, because we spent a lot of time doing that this first time around.
So it sounds like from the standpoint of preventing this from a year from now, you all have certain benchmarks in mind to reach with the providers to ensure that everyone's on the same page. Is that what I'm hearing?
Yes.
Yes, and we've already started those discussions with the carriers, and our plan is to have, in the near future, start that conversation, ensure that we have a product well before the reporting is required to ensure it's clear and understandable and in place. And one of my biggest goals as well is to ensure the efficient submission of that information and the clarity of that information as well.
Thank you, gentlemen. It's wonderfully helpful. I think for all of us, just hearing a little bit more in depth about what the process will look like. And as Senator Lesser, the chairman, indicated, we want to make sure you have the resources to do that. And so that we can really bring transparency and bring this data more to light. And if there is anything as you go through this next year that is additionally helpful, please bring that forward to us, because we want to make sure that when we get here a year from now, we're not having the same conversation. So thank you for being here and for those answers.
Thank you, Representative. And I see Representative Meskers has joined us again, and promise we didn't boot you from the meeting, Representative. Before I turn it back to Representative Meskers, I just had a follow on Representative Farrar's question. You know, I appreciate that you're hopeful that this additional guidance will mean that the next time we hold this hearing, the industry will be in substantial compliance with the law. As lawmakers, our job is to figure out whether or not we need to tweak the law in any respect, and the timing here is not super conducive to the legislative session. We're sort of at the end stretch of things. What point will we start to get a sense? Will you start to get a sense of whether or not the comparative analysis is sufficient, whether or not the industry is in substantial compliance? So I think we're going to be looking for guidance going forward about whether the law as it stands is sufficient or whether additional tweaks are necessary. So I'm wondering if that'll be, in May of next year, by the time after the end of the legislative session, or will we be able to get real information sooner than that about whether or not the current scheme is working?
Senator, I think to be responsive to that, I think, we are analyzing the data now. I think our hope is to have findings and a plan with how we will take action if it is appropriate, hopefully by the end of the year, would kind of be a goal that we would have.
And so based on that, we could have discussions with the commissioner or his designee about potential legislative changes if they're necessary based on that by the end of the year. But that would give us time because we'll be back in February. Okay. Thank you. Representative Meskers, sorry that you were booted off earlier.
No, my daughter in Washington loves to FaceTime, and I didn't have my glasses on. And instead of hanging up on my damn daughter, who I love dearly, I hung up on you. So I was very frustrated. And she got to hear my expletives, so it was just as well that I was hung up because I was so frustrated.
Well, we're glad you didn't hang up on your daughter.
No, that's right. She's 25. She's used to it. She's dealt with me before. So going back to the commentary, I appreciate that. I'm getting the message from you that the compliance issue is a function of the somewhat subjective nature as we are implementing the regulatory reporting framework for compliance with the insurance regulation. Now, I guess the only other point that I had or wanted to ask is that we feel this is an imperative issue to ensure equity in healthcare. And so the only problems I see is that you don't cover either the self-insured market, which I guess is a regulatory framework because it's outside our purview because it's regulated by NAIC at the federal level. But importantly, you also don't regulate the state mandated plans, whether it's the pension, whether it's the state employees or the municipal employees that are under a state plan. So I think as a question, the amount of resources you have and the market you're covering now, do you have adequate resources if we were to expand the requirement of your coverage to cover either the municipal employees or the state employees with this reporting requirement?
Yeah, Curt's not on. I mean, Curt is the director of market conduct. If you're asking me, and my perspective is that with what I see coming down the road and what's being developed for a standardized practice, I think we can to evaluating that for parity and equity, because we've done a lot of work. We're, not to toot our own horn, but the Connecticut Insurance Department has done a pretty extensive job in looking at data points, and if that's the claim activity and every type of measure that produces a non-quantitative treatment final outcome. We've put together a program, and it's very extensive. It's more extensive than New York, and New York's is pretty good. I looked over it. Ours is good, and it's going to get better. But having that structure, that template, the standard, whatever you want to do, so that if there's more plans that are going to come over into our purview or oversight, I think we'll be able to effectively evaluate them and assess them.
Okay, perfect. Thank you very much for that.
Thank you, Representative. Other comments or questions from members of the committee? And I will say, I just got to, you're not the only one, I think, who's having some connectivity issues. Representative Veskers, I think we're still, I think we lost Curt.
Nope.
So,
Okay.
so hopefully we get him back. Are there other comments or questions from members of the committee? If not, thank you to Curt and Rob for their testimony, and we really appreciate it, and we will continue to work with the department on this issue going forward. We didn't think we had solved mental health parity with one law, and I think we may have to have additional efforts going forward. So thank you both, and always appreciate the work of the department.
Thank you very much.
We have Hillary Felton-Reed from the Connecticut Association of Health Plans.
Good morning. Senator Lesser, Representative Wood, Senator Wong, Representative Pavlak-D'Amato, and members of the Insurance Committee. My name is Hillary Felton-Reed. I'm a lobbyist with Robinson & Cole. I'm here on behalf of the Connecticut Association of Health Plans. And my colleague Susan Halpin is also on today, who I know needs no introduction for all of you. I'm here to present comments regarding the mental health parity non-quantitative treatment limitations report that were due pursuant to Public Act 19-159. Behavioral health illnesses and substance use disorders are a critical focus of the healthcare delivery system, particularly as we face an ongoing opioid epidemic, a growing number of mental health cases emerging from the COVID-19 pandemic, and increasing incidents of youth and psychiatric crisis. Health insurance carriers in Connecticut share the concern of policymakers, advocates, and families as it becomes more evident a new mental health crisis is upon us. Carriers are taking steps to meet the demand, including offering a broad array of coverage for telehealth, increasing availability of 24-hour mental health treatment hotlines and digital apps, and supporting local organizations such as Mental Health Connecticut and their 31 Days of Wellness campaign, and coordinating with Connecticut's Access Mental Health program. Additionally, under the leadership of Commissioner Mays in the Department of Insurance, CTAHP is involved in discussions with various stakeholders to strategize around the recent influx of youth in psychiatric crisis presenting to the EDs. The association worked in good faith on the passage of the Public Act in 2019. As one of the first states in the nation to adopt this level of reporting and analysis contained in the reports before you, Connecticut is at the forefront again of promoting parity in mental health treatment. Data is a critical component of any healthcare delivery discussion, and this act was an important step to bring accountability to a law which has been in place at the federal level since 2008, but which has remained challenging to implement and evaluate for carriers and regulators alike. NQTL compliance specifically remains complex. So advocates and regulators have looked to analyze data in a manner adopted by Connecticut in Public Act 19-159. Again, as one of the first states to adopt this level of intense data collection and analysis, we have learned lessons along the way, and we hope those lessons will be reflected in the future reports to come. Data collection is complex, and it will take time to paint a picture that is actionable. The new requirements at the federal level adopted in the 2021 Appropriations Act in December of this year do closely align with Connecticut's law. The newly revised federal self-compliance tool used to be a tool that was designed for carriers to determine internal compliance with mental health parity. That used to be a tool that should be used for their own operations, and that now will become mandatory under the new federal changes adopted in December. Additionally, carriers will be required to report this information to the federal government, and federal agencies will produce summary reports to Congress, similarly to our law.
Excuse me, your 3 minutes are up. Please summarize.
Okay. I will just say that this was a very important step to bring accountability and transparency to mental health parity compliance in Connecticut. We have been in discussions with the department about how to better the collection of the information that they're looking for to ensure that their standardized approach, as has already been discussed in this hearing. We have a strong willingness to ensure that the law that was enacted is implemented as intended, and we are looking forward to having continued dialogue with the department and with all of you moving forward. I'm happy to answer any questions.
Yes, well, thank you. And Hillary, I'll sort of echo my the same questions I had for the department, the representatives in the department earlier. We passed the law 2 years ago. I understand that the additional federal guidance came out in December, but the department laid out a bunch of tools that are available to the industry. And yet they indicated that there was substantial non-compliance with the provisions of the law. So at what point will we know whether or not the industry is in compliance with the 2019 law?
So I first do want to, I don't believe that the department has indicated yet non-compliance with the law. I believe that they have indicated that there's still some additional information that they're looking for. As I mentioned, we've been in discussions with them as they're furthering their review of what's been provided. The reports and the information that has been provided are extremely voluminous. I'm sure you all have taken some time to look through what has been provided so far. There are several attachments and exhibits actually that were referenced in many of those reports that I'm not sure have actually been provided on the committee's website yet. So I do think that there is a lot of information there that we're all still processing. I'm seeing the reports just as you all are. I think that again, we are actively already pursuing discussions with the department to ensure that there's clear expectations of what information should be provided. I think that what has been most confusing is the expectations around specific analytics or, specific data. Even the federal guidance and the federal requirements do not outline specific analytics to be collected or analyzed. And I think that is where a lot of the confusion lies. And there were not specifications really provided by the department. And that's not necessarily a fault of theirs, but I think also, again, as it has already been mentioned in this hearing, just a lack of understanding of exactly what specifications should be used to demonstrate the comparative analysis that they're looking for. Again, there is a true willingness on behalf of the carriers to implement the law that was enacted in 2019. We worked on that law very much with all of you, and we are committed to implementing it as you intended. So we hope that we can have additional discussions on the exact reporting template that is to be used, which I think will help to provide some more consistency. And again, the changes at the federal level in December of just this year, there is to be more additional guidance that will come out 1 year from now, in about 1 year. That guidance is directed at NQTL analysis. And NQTL analysis has been, as I mentioned, the area that is most complex for people to digest and to understand, and the area that has lacked guidance over time. So the new changes at the federal level hopefully will bring consistency across the board, across states, and not only help provide the carriers with additional understanding of what the expectations are, but hopefully the state and the department as well.
Thank you. And I appreciate that answer. And I also echo I'm grateful that the federal government has taken action and passed national guidance that will hopefully help bring the industry into compliance with the NQTL issue. I guess I echo my frustration that I expressed earlier, which is that the policy of the United States, it's expressed in Congress and then through each of the states, has been that we want parity, and it's been that way for decades. And yet, I think we've heard from the public, we've heard from the department, that is yet a reality. And so I understand the industry is saying that this is confusing, that there's been a lack of guidance from the department until recently. I hear those excuses, and I understand them, but I also understand that these are some of the largest and most sophisticated companies in the country, and at least many of your members are, and would hope that after decades that we can finally get to a point where we have full mental health parity, and hopefully we can get that very, very soon. And if we don't, we'll have to pass additional legislation. But it's how many laws do we need to pass before this is a reality? Other comments or questions for Hillary from members of the committee?
And if I could just respond to that, if there aren't
Sure,
any other.
absolutely, yeah.
So I just wanted to emphasize that the carriers do not object to mental health parity, and we are not objecting to that right now. And I also am not sure, again, I just want to make sure that it's clear. I don't think that it has been alleged in the reports or in the report from the department that anything that has been provided so far indicates a non-compliance with parity or even a lack of parity. And I do think, there's further review to be had, and we'll see, what results come of that. But I do have to just emphasize that the carriers have been diligently working to understand what the department and the state is looking for in these reports. We've had many, many conversations to try to better understand the expectations there, with the intent of implementing the law and remaining, because I think that many of them are intent on being compliant with parity now and remaining in compliance moving forward. So we're actively looking to engage in the mental health discussions moving forward. It's something that is very recognized from all carriers.
Thank you, and I do want to thank you for your work with us 2 years ago. I do recall that you really did get in the weeds, and I appreciate that. And so thank you for working with us on this issue. And if I express frustration, it is not directed at you personally. I know that there is a recognition on all parties that this is an important issue, and I'm just hopeful that we will see the data in place that the department needs. Other comments or questions from members of the committee? Seeing none, thank you for your testimony. I think next up we have Susan Halpin.
Thank you, Senator.
Thank you, Senator. And good afternoon. Oh no, still good morning. Sorry, it feels like afternoon. Just want to say thank you to everyone. And Hillary and I are actually tag teaming today. So I just wanted to add a couple of things to the conversation. Hillary is being very modest. She had spent a considerable amount of time at Anthem working in their parity department when she made a brief hiatus from Connecticut down to Atlanta. And I'm pleased to say that we lured her back here to come work for us, and are thrilled to have her back. So she does bring to the table a considerable amount of expertise. The other couple things I just wanted to mention is, Connecticut's always been at the forefront of mental health parity. And the good senator alluded to the state's leadership in that respect a while back, and the industry has always been in those discussions and at the table from the outset. I think if I could just summarize very quickly the conversation that I heard today, is there's several different aspects of mental health parity, and I think we've accomplished a lot of them. There's one left, and that is really how to measure, not implementing, but how to measure NQTLs. And I do want to reiterate some of the things that have been said about our department. Connecticut's laws and guidance and tools have often been modeled by other states and the federal government. And so I think that they, again, have been at the forefront of this conversation and really shaping these policies going forward. So, we understand the frustration, but we are also dealing with repeated changes as time goes along. So even if you have a tool that is being implemented, if new guidance comes down from the federal government in just, December or February of this year, then that, changes the landscape and everybody has to pivot and adapt to that. So I just wanted to point out those few things and also just, say how pleased and fortunate we are to have Hillary on the team. So thank you.
Thank you, Susan. Any questions or comments from members of the committee? Seeing none, thank you for your testimony. Next up, we have Susie Craig, followed by David Lloyd.
Good morning, Senator Lesser and members of the Insurance and Real Estate Committee, Representative Wood, Representative Comey, Senator Anwar, and other members. I want to thank you for holding the hearing. Thank you for this discussion. And I especially want to thank this committee for all of your work in 2019 to truly be the bridge. So my name is Susie Craig. I am from Mental Health Connecticut. I also help lead the Connecticut Parity Coalition, and we work very closely with this committee who helped build a bridge with the insurance industry to really work through how we can get this done, right? You have my written testimony. I don't think I need to go through a lot of what's been discussed today. I do want to point out a couple of things about where the Parity Coalition stands that I think is really important for moving forward. There's been a lot of discussion today about gaining clarity and the complexity of the data. And I just want to reiterate some things that have been said, particularly from Senator Lesser, about the fact that the federal law has been in place since 2008. So we've had 13 years. And I think when that law came out, it's my understanding that everyone knew right away that it was too complex, that we needed to understand how to get this done. So that's why these parity laws have come to be. This law basically says we need to comply with the federal law, right? So when the Connecticut Parity Coalition in 2018 and 19 was setting out to figure out how we could ensure that this happens, that compliance is actually happening, we went to experts from across the country and folks that were working on building best practices and creating the model for this legislation. So please understand, for some of the legislators in this committee who are not familiar with the backstory, that there are 30 other states across this country who have used this model effectively, and they're in varying degrees with their progress as well. Some of them are further along, some of them are behind Connecticut, but please know that this legislation is based on those best practices and models. So we have the tools, and with what's been mentioned before, it's the self-compliance tool from the DOL and other guidance out there. So I have to say, it is a little bit frustrating to hear that there isn't clarity on how to understand if compliance is happening, because we have all of these resources at our feet, essentially. So here's the request that I would like to make. Because I'm hearing a lot of, well, next year. That feels way too long for me. I feel like since we've had 2 years to understand what compliance looks like in Connecticut, that I would like to suggest, and I know we're running out of time with the legislative session, but can we amend the 2019 bill to change the timeline? Can we have another public hearing in November, December, to hear from the insurance department to see where they're at?
Excuse me, your 3 minutes are up. Please summarize.
Okay, thank you, I will. So my request is essentially, can we revisit, and as Senator Lesser was suggesting, tweak the current law or improve and accelerate this process? Because we've already been waiting for the data. So the data is coming in, and now we need to put those best practices and those tools in place to accelerate that clarity so we can understand where compliance is happening and where it's not. Thank you.
Thank you, Susie, and thank you for that suggestion. I think well, this committee can always hold a hearing at any time, and we can ask for information from the department. Where I think we might come into trouble is if we're changing the timeline on reporting data from the industry. There might be some implementation issues. So I can see that being a potential barrier. But just speaking for myself and not for the committee as a whole, I don't see an issue with us coming in at some point prior to, where statutory time to have a check-in with the department to figure out where are we, do we need to make additional improvements? It may be more complicated to say, hey, we're going to now require reporting data every 6 months by the industry as opposed to annually. That I can imagine, and I don't represent them, but I could imagine that might be a problem just in terms of implementation. Representative.
Thank you for your testimony, Susie. I just wanted to say that, as long as we are following the rules, and I would love to have a follow-up. And, I think that there's a need for us to really address these concerns and do as much work as we can in the off-session time on just expanding the bench of our mental health care providers and really taking this issue and making it a top priority, considering everything that we have been going through and what we're hearing from our constituents. And I just want to say thank you for those suggestions, and we will definitely take them under consideration.
Thank you, Representative Wood. I appreciate that.
Thank you, Representative. Other comments or questions for Susie from members of the committee? If not, thank you very much for your testimony. We lost her already. Harsh but swift justice there, I guess, on this committee. Next up, we have David Lloyd from the Kennedy Forum.
Great. Thank you, Senator Lesser and Representative Wood and members of the Insurance and Real Estate Committee for the opportunity to testify today. My name is David Lloyd. I'm a senior policy advisor with the Kennedy Forum, which was founded by former Congressman Patrick Kennedy, lead author of the Mental Health Parity and Addiction Equity Act. In close partnership with the American Psychiatric Association, we've been working across the country to improve oversight and compliance with the federal parity law. And we certainly applauded the Connecticut law, Public Act 19159, back in 2019. Connecticut was one of the first states to act and has now been followed by roughly half of states enacting or having similar requirements. Connecticut also helped pave the way for important recent federal action with the enactment of the Consolidated Appropriations Act of 2021, which amended the federal parity law to explicitly require plans and issuers to conduct detailed parity compliance analyses that are nearly identical to what is required by Connecticut law. Given the COVID-19 related increases in mental health and substance use needs, thorough review of these analyses are now critically important. Fatal overdoses have surged in the last year with a 13% increase in Connecticut alone. So the analysis of what plans have submitted can literally mean the difference between life and death. I will say that the federal NQTL rules, as well as rules on quantitative treatment limitations and financial requirements, have been in place through regulation since 2014. So insurers have had more than 7 years to comply. Yet across the country, insurers are still not adequately complying with the federal parity laws and NQTL rules and falsely claim that guidance has been shifting in a manner that prevents compliance. Frankly, I think there should be a little sympathy for insurers who are not complying with the NQTL requirements. When patients are subject to these impermissible treatment limitations, it is not a mere convenience. It can mean deterioration, disability, bankruptcy, homelessness, and even death. So the experience of these patients should really be put at the front and center of all these conversations. In April, the Department of Labor issued new guidance on the Consolidated Appropriations Act, which simply said what should be in these analyses and simply said that generalized statements without specific supporting evidence and detailed explanations of compliance were insufficient. So I think Connecticut should insist on sufficient analyses consistent with the new federal guidance. Connecticut can also request at any time plans parity compliance analyses under the new federal rules, and they should do so to demand that plans submit sufficient compliance analysis if the initial rounds were not sufficient. So this, just in closing, this is a critically important area. We've been working with other states to help them beef up their parity compliance analyses of these reports and to have the expertise needed. And we're happy to work with the Connecticut Insurance Department to make sure that we're finally making parity reality in the state of Connecticut. So thank you for the opportunity to testify. Happy to answer any questions you may have.
Thank you, David, for that. And I also want to thank Patrick Kennedy, who was a really terrific partner on the ground with us when we passed this 2 years ago, and a part of a coalition, including Tim Clement, who couldn't be with us this morning. And we really appreciate all of the work of the Kennedy Forum on this. Do you have, I mean, I share your frustration, the rules being in place since 2014, and yet, we hear the confusion remains and we have a lack of clarity about how to comply. I'm very frustrated that the department isn't able to say that it has the information required by the law. Do you have suggestions, or are there things that other states are looking at about how, is there any additional action, legislative action that Connecticut needs at this juncture that you think would be helpful to getting that data to ensuring compliance with what we need to do to figure out if parity is in fact in place?
Yeah, so I don't want to tell you not to pass additional legislation, but I think that your existing legislation should have the tools that are really needed. And the department earlier testified that it's working with the NAIC, MAPIA working group, which is terrific because they're really working on best practices and really having consistent reporting, forms, et cetera, to help standardize this so that plans are not having to fill out 50 different forms across the country. And we certainly have been pushing that, and had our 6-step, compliance reporting, which really aligns with the Department of Labor's self-compliance tool. So, I think most of the reporting templates tend to be aligning now. I think that the department, at least in my reading of the new federal law, has the power at any time to go to the departments, to the plans and say, we want your parity compliance analyses, and if it isn't meeting these standards as laid out in the Department of Labor guidance, we want you to update them and produce the materials in a manner that we think do demonstrate compliance. I'd also say that in terms of the in-operation data that is collected, which is absolutely essential, if those show disparities and the parity compliance analyses are not sufficient to demonstrate compliance or explain why there are differences, I think it's our view that the plan should be deemed to be not compliant. And whether that means just corrective action or whether it means fines, I think that's up to the department. But if there aren't sufficient analyses, we are encouraging regulators across the country to demand that those analyses be made sufficient. And if the realities of how the benefits are constructed or being operationalized don't allow a conclusion of compliance, then the underlying benefits or how they're operationalized must be changed. So we think that there's obviously this takes time, but there's really not much time to waste given the increases in need we're seeing, and putting patients first in this discussion we really think is critical.
Yeah, I agree with you on the time sensitivity, and we'll work with the department to see if that's the case. So do you think that the standardization of the forms by NAIC is something that's likely to bring the industry into compliance with the reporting, with the comparative analysis reporting requirements? Is that?
Well, I certainly think that having more consistency across states will help. several states use, mostly forms of mostly line with slight differences. Those differences really should not inhibit compliance in any meaningful way. Many of these insurers are large corporations, which should frankly have the ability to meet different states, regulatory requirements, as well as the requirements of the Federal Parity Act. So, certainly think things should be, streamlined and made consistent, but where there are slight differences, I don't think that's any excuse for not complying with any state or federal law.
And so this may be an unfair question, but we got a massive data dump from the industry that we're now privy to, and I understand. And now analyzing that data is the hard part. That's what the conversation today is about. But I didn't know if you had a chance to look at the data that we did get and make any heads or tails of that. Is that something that you have the resources or the time to do?
Yeah, I think it's a major problem when there are these huge data dumps and this huge production of documents, which frankly are sometimes designed, if not designed to mislead, have the effect of not being able to make heads or tails of what is actually happening. I do have the guidance from the Department of Labor right in front of me, and I'll just quote it. They say that, quote, generalized statements without specific supporting evidence and detailed explanations or mere production of a large volume of documents without a clear explanation of how or why each document is relevant to the comparative analysis is insufficient. So to the degree that that has happened in Connecticut, and I've looked, I haven't, gone really deep into everything that was submitted yet, but to the degree that that's happened, I would think that the department should demand that particularly with this new guidance from the Department of Labor, that what plans submit their comparative analyses that are now required under federal law, that those should be corrected in a manner that is consistent with what the recent federal guidance suggested was necessary, or actually said was necessary. So I think that if there's just been a massive data dump, the department should work to correct that so that they can actually have the data they need and the analysis that they need to actually determine compliance for each UTL.
So the conversation today is largely resulted around when are we going to get the comparative analysis in place? And what you're telling us is that under the federal law, the comparative analysis should be in place at any time. And so we don't necessarily need to pay attention to the Connecticut law about reporting to the department. The department, we could decide to hold a hearing in November and December and January prior to the next legislative session. Ask the department provide updated comparative analysis reports, because those are things that the industry should be providing on an ongoing basis anyway.
Yeah, as of, it was 45 days after enactment of the federal Consolidated Appropriations Act, which was February 10th. All plans had to have these parity compliance analyses conducted. Now, it didn't say in what, exactly what form that had to occur, although the Department of Labor laid out, guidance of what it must contain. So even though, Connecticut and other states now have an annual reporting requirement, the Consolidated Appropriations Act makes very clear that any, state insurance department can request at any time the under federal law, the plan's comparative analysis. So I would think that that would provide a powerful hook for the department, to really demand that the analyses that they have already received and the plans under federal law are required to have conducted at any given point, that those be sufficient to demonstrate compliance. So I think the two working hand in hand can be quite powerful. I would defer to you on what the committee can do at any given point in time, but that would make sense to me.
Right, and just in terms of timeline, in terms of the NAIC standardized reporting, to the extent that that's the excuse for why the reporting isn't up to snuff. What's the timeline on when that will be streamlined or
Yeah, so, so it's a working group. So I don't think that they have power to impose upon the states that are working as part of that working group on like, these are the forms that, you should use. It's more of a sharing of best practices and tools to hopefully harmonize them across states. But I think it's then voluntary, for each state to use the tools that, hopefully more or less align with each other. But, I think the idea that, we simply don't have the form, we simply don't, there may be guidance in the future. I view those as largely red herrings, but I do agree that we should be working towards standardization, across the country, and that will help improve compliance. But that's definitely not an excuse for why there would be, non-compliant in QTLs.
Got it. Thank you very much. Other comments or questions for Mr. Lloyd from members of the committee? If not, thank you very much for being here today. In the list of folks that we had publicly released who were scheduled to testify, David was the last person that we'd had, but it was brought to my attention this morning that Missy Olive had attempted to register and had been unable to do so for technical reasons, and she's with us here today. So with the committee's indulgence, we have Missy, and Missy will be the last person to testify before the Insurance and Real Estate Committee. Missy, the floor is yours.
Thank you, Chairperson Lesser and Wood, and also Ranking Member Swann and Pavlak D'Amato, and the remaining members of the Insurance and Real Estate Committee. I'm Dr. Melissa Olive. I'm the Chief Clinical Officer for Cultivate Behavioral Health and Education. We have 11 states that we provide services in, including the state of Connecticut. I'm not here representing Cultivate, but rather the Board of Directors for the Connecticut Association for Behavior Analysis. I am the chair of the Public Policy and Legislative Outreach Committee. On behalf of CTIB, I want to thank you all for, first, the telehealth bill that you all worked very hard on. We're super appreciative of that. And also thank you for the time today on mental health parity. I would like to note that my PhD advisor was Dr. Mary McAvoy, who was tragically killed in a plane crash with Senator Wellstone. And as you all know, Senator Wellstone did an amazing amount of work on this very topic. I did submit the written testimony so you all can look over that. I do just want to point out a couple of things. These location limitations that we're seeing, especially from Aetna and also previously from Optum/United, this is a serious problem. As you know, particularly limiting the services in schools is problematic. The schools do not have the resources to meet all of the behavioral challenges for these individuals, and they are more than willing to work alongside behavior analysts in addressing those needs. And so we need to stop these non-quantitative limitations of location. As you know, it does not happen on the medical side. We also want to point out that children with autism are often the only ones who are allowed to obtain the applied behavior analysis therapy, ABA therapy. And that is really unfortunate because other children, as demonstrated in our research literature, benefit from ABA, and they should not be discriminated against because they don't have the right diagnosis. I know this is not a quantitative limitations hearing, but we submitted a great deal of data for you all to better understand the kind of quantitative limitations that our patients are receiving or not receiving when we submit our treatment plans. And I think it's really important to note we provide an intensive service. So every 6 months, we're required to submit a report asking for those hours for the next 6 months. And those reports are anywhere from 50 to 70 pages in length in order to document the medical necessity. And I'm quite sure that the medical side does not have to submit that same type of documentation. I do want to point out that Representative Nuccio's point about diagnosing is also spot on. We know that we can diagnose children with autism as early as 12 months, and yet the average age of a diagnosis for a child with autism is 5 years. And so that window of when they should be diagnosed to when they are getting diagnosed is partly due to the lack of availability of clinicians to provide those diagnoses. I finished early, which never happens. Are there any questions?
Thank you. And I did have a chance to see your written testimony, and there's quite a lot there. And it does raise some questions, and I think we could have some conversation with the department and the industry about the specific questions that you raised there. So I want to thank you for your testimony. I'm glad we were able to figure out a way to solve those technical issues here this morning.
And please note, Connecticut ABA is more than happy to work with y'all in any way. I also met a few people today, so we're super excited about connecting with other people.
Great. Thank you very much, Doctor. Are there questions or comments from members of the committee? If not, thank you very much for your testimony. And with that, we have concluded this the list of people scheduled to testify for the public hearing. I just want to thank everyone in the committee for its indulgence. This is an unusual time for a committee public hearing. We did that because of the statutory language in the law passed in 2019, and we don't plan on having too many more public hearings of the insurance committee this legislative session. We'll go back to your regularly scheduled legislating. And with that, thank you very much for everyone for joining us today, and stay tuned. We may plan additional action on mental health parity in the future. Take care. And with that, I would move to adjourn the public hearing.
So moved.